Hello, good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. As you know, doctors, this webinar is brought to you by Heathrow Healthcare, which is an innovative pharmaceutical company. The Heathrow Healthcare journey began in 1993 and has 30 plus years of excellence and 36 state-of-art manufacturing facilities. With 300 plus products in the portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. It's amongst the largest manufacturers of ARVs, APIs, and FDFs in the world, and Heathrow Healthcare has Asia's largest API manufacturing facility at ACZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, introduced Oseltamivir, Favipiravir, and Remdesivir, and for which they received an award of Pharma Excellence for COVID drugs in August 2020. Today's webinar, role of Oseltamivir in flu management, we have got Dr. N. H. Sridhar sir as our moderator. Welcome, Dr. Sridhar sir. And Dr. Sri Krishna and Dr. Sankoj as our speaker. Welcome, Dr. Sri Krishna, and welcome, Dr. Sankoj.
Welcome.
Dr. Sridhar sir is practicing since 20 years. He is professor on Apollo Institute of Medical Science and Research, Director Neo BBC Hospital, Hyderabad, Treasurer Secretary Twin Cities Branch 2021, 22, 23, 24, Joint National Coordinator CIIP 24-25 Presidential Action Plan, Secretary PATS 2025-26, Medical Legal Expert. Major achievements include 7 national and 1 international publication, Additional Chief Organizing Secretary Pedicon 2025, Organizing Secretary APPA Pedicon 2016, Pharma Trade in Charge in all conferences since 2016, Vaidya Ratna Award 2023 from Dr. B.C. Roy, Motherford. Welcome, Dr. Sridhar, once again. Dr. Sri Krishna Surampudi, sir is MD DNB, consultant physician, pediatrician, professor and head of the department Pediatrics, Apollo Institute of Medical Science, Hyderabad. Welcome, Dr. Sri Krishna.
Welcome.
Dr. Sankoj Bhaskar sir is Director of Paramitha Hospital for Women and Children, working as consultant pediatrician since 1989 with 35 plus years of experience. President, Pediatric Academy of Telangana State 2025 PATS, Treasurer Pedicon 2025, Chairperson Pediatric Intensive Care Chapter of Telangana State PICCKTS 2023. With this brief introduction, I hand over the session to Dr. N. L. Sridhar for further deliberations. Over to you, sir. I should stop sharing.
Thank you, Prashant, for your nice and brief introduction about moderator and panelists. Thank you so much. And one second. Able to see?
Yes, sir.
Yeah, that's great.
Yeah.
So, first of all, from a panelist and from moderator myself, we want to thank Heathrow Healthcare for giving this good opportunity. Both ways, we will benefit with the subject what we got because of these discussions, and also we can enlighten the practicing pediatricians and also postgraduates, anyone who are listening here, what the role of Oseltamivir in flu management. This is a beautiful panel discussion having a exact original cases taken from Apollo Institute of Medical Sciences. Thanks for head of the department for permitting the cases to be presented in this webinar. And coming to the contents, since you know very well the time when the monsoon comes and post monsoon, these influenza cases are will be increasing day by day. So that's why the contents are healthcare challenges in monsoon and their diagnosis. In the brief introduction about the types of influenza and its complications, and clinical evidence of Oseltamivir, because we have very few drugs for the influenza, but one of the golden drug is Oseltamivir. So the clinical evidences we want to show, and also guideline recommendations of empiric use of Oseltamivir. So you know very well, since the influenza incidence of influenza is more in monsoon and post-monsoon, since monsoon is extended in Telangana and other states also. Till now also we are having rains, and the climate is a bit changed with the more rains and more cool atmosphere. So there are that's why the influenza cases are more nowadays also. We have seen yesterday also, we have seen one case. So like that, the cases are increasing day by day. And so we have to think of the so many viral infections in monsoon time. So which season is more predominant for the flu? And what will be the correct time to vaccinate? So these are the three heads we have to discuss. And the Indian data is important before going to the which months it will be raised. The 5 to 10% of all the acute respiratory infections are due to the influenza. 10 out of 100 children suffers from influenza. And also, there is an instance of 178 to 180 cases per 1,000 children per year below 1 to 2 years. There are two different studies from North India which have shown this data. And influenza associated with acute respiratory tract infections is very common in 30 to 44% of 1,000 children per year. And we have two pandemics, one in 2009 and 2019. Both the pandemic has seen more incidence of cases of 22.8 positivity for influenza. And in 2019, there was a rise of cases of 30,766 positive cases with 1809 died. So this is the graph taken from the our own purple book of vaccinology from IAP. So this has shown, if you plot the diagram, the incidence of more cases are shown from January to the first peak is shown in January to April, and second peak is seen in July to October. So we have to keep in mind when the surge will be there of the cases. So the best part of the vaccination should be before. Like that means if you give the in November, December, the first peak will not be there for the child, will not be having the suffering. And if you give in May and June, the second peak, which is July and September or October, that will not child will not be affected if you vaccine the child. So these are the mortality, morbidity, and hospitalization due to influenza, lower respiratory complications, where I will tell only two lines of in this table. It is taken from Global Burden of Disease 2017. By 2017, the number of cases hospitalized are 5,88,000, and out of which 26,000 deaths are there. Year wise, that was total cumulative. Here it was a year wise cases and deaths are taken. I'll mention only 2022. That's the latest consideration taken. So that is case number of cases in 2022 is 12,881 and deaths are 399. So with this table, we can see how many deaths are there, how many cases are there, and this is very important to diagnose the case and have the clinical interpretation, and also to start the Oseltamivir early so that we can prevent death and also morbidity and both the morbidity and mortality. So some pattern of circulating strain. We have four strains: H1N1, H3N2, Victoria, and Yamagata. See, these strains, there may be difference in one zone and another zone. And the peak may be in central zone, central India, the peak will be seen in July to September. North, January to March. And south, it is common in September to November. And as I said earlier, winter and post-monsoon, the peak will be very high for the influenza. And there was a 7 years cumulative study which has shown influenza positivity with the onset of monsoon and peaks during the post-monsoon months. So this study was done in King Institute of Preventive Medicine and Research in Tamil Nadu, and total 36,670 samples are subjected in 7 years. So the in 36,670 cases, the influenza positivity is seen in monsoon and post-monsoon. And when this is the incidence of infection, now coming to the scenarios and subject of the influenza, we have to keep in differential diagnosis for the influenza. So the healthcare related challenges in monsoon are few cases. Influenza like illness is seen, H1N1, what we are discussing today, and severe acute respiratory illness and COVID-19. These are all the healthcare challenges which are commonly seen in monsoon time and post monsoon. So we have to keep in mind to differentiate this diagnosis, because influenza like illness will be having can be caused because of the other viruses also. And the common viruses RSV virus and adenovirus, where we can see the mixed infections also. Along with H1N1, RSV can be seen. And along with H1N1, we can see dengue. These are all the mixed infections where we have to keep in mind. So influenza like illness, the severity will not be there like H1N1. The myalgia, headache, body pains, malaise are less when compared to H1N1. And in acute severe respiratory illness, this is similar to H1N1. The severity will be there, breathlessness will be there, tachycardia will be there, and symptomatology is more related to and bacterial mixed infections, added infections are seen. And in COVID-19, yes, we have to keep in mind COVID-19 is a multi-system involvement case other than respiratory. It involves loss of smell and loss of taste, and also GE symptoms, diarrhea, vomitings will be common with COVID. So we have to keep in mind these are the how to eliminate the by symptoms and clinical scenarios. We have to differentiate the diagnosis and confirm the H1N1. This is a bar diagram where the incidence of infection of influenza is shown in 28,798 in 2019, and out of which 18 other deaths. So till now we have seen the incidence and types of this variation, differential diagnosis. But now, what are the brief note on these types of influenza? Influenza A, B, C. These are the three variants we have seen, and the influenza A causes 60 to 70% of the infections. Influenza B will be causing around 25 to 30%, and few 5 to 10% influenza C, whereas influenza A causes frequent epidemics and periodic pandemics. Influenza B, local epidemics. Influenza C, less to cause epidemics. And as earlier said, out of these four subtypes, H1N1 and H3N2 are very common. Victoria and Yamagata are less. And transmission of flu virus is how the flu virus transmits. Is similar to other flus, other viruses. It's a droplet infection, and it can spread from 6 feet away from the other infected patient. And these droplets, what happens is it lands in the mouth, enters into the oral cavity, and enters into the lungs, causing the respiratory epithelial inflammation, causing alveolar inflammation, and causing this pneumonia and other influenza affected lungs. So people should stay away from the affected person and stay home if sick. And it's also important to wash hands often with soap and water. And most healthy adults may be able to infect other people beginning 1 day before the symptoms and up to 5 to 7 days after becoming sick. So most children will passing the virus longer than 7 days. As I earlier said, symptomatic differentiation. We have to see only one influenza-like illness and H1N1. This breathlessness is very much common with H1N1. And second is how to differentiate severe acute respiratory infections and COVID-19. The headache will be very much common in influenza. So here may or may not be there in influenza-like illness or SARI or COVID-19, but make sure that the common is the headache will be there in influenza. That's why headache, body pains, malaise, weakness is more prominent when compared to other things. So benefits of empiric and early use of Oseltamivir. There are so many clinical trials, and all are shown that better you start early empiric treatment with Oseltamivir in influenza illness. So child will be benefited by this is a prospective study. Data on lower respiratory tract complications and antibiotic use from 3,564 subjects with influenza-like illness enrolled in 10 placebo-controlled double-blind trials of oseltamivir treated with was analyzed. In patients with influenza, if empiric treatment started with oseltamivir, it reduces antibiotic use by 26.7% and influenza-related lower respiratory tract complications resulting in antibiotic therapy by 55%. This is a good news for the patients and also practitioners hospitalization was reduced by around 60%, 59%. So this is the brief introduction about the things. Influenza is RNA virus, which is much important. Why the expiry of the vaccine is only 1 year, because the strains may change because of changing genetic sequence in the RNA virus very rapidly. We will not be able to know the subtypes we know, but the genetic sequence changes. So giving a vaccine which doesn't have a proper genetic sequence is a waste for the patient. So that's why every year we get this the lot of manufactured companies will be giving the by May June the fresh lot that can be given 1 year. So that's keep in mind this RNA virus, which prominently changes the genetic sequence very rapidly. So this is the introduction. Now my panelists, I welcome my panelists, Sungoj Bhaskar sir, President PATS, and also Surampudi Srikrishna Garu is the head of the department and professor of pediatrics in Apollo Institute of Medical Sciences Research. I welcome you both, sir. Now it's a time for Surampudi Srikrishna Garu to start with the case one discussion, sir. Please go ahead, sir.
Good afternoon, everyone. I thank Hetero and also the PATS team for giving this opportunity. As everyone knows, nowadays from last 3 months, there is a sudden surge of influenza cases. And we had some interesting cases here. In this one case is a 4-year-old boy admitted with a history of fever for last 6 days, along with cough and cold since 5 days. The child is having a respiratory rate of 45 per minute, along with the irritability. On examination, there are bilateral crepitations, whereas other parameters are normal. The weight of the child is 15 kg. That means 4-year-old 15 kg is appropriate. So the normal healthy child is having this particular problem of fever, cough and cold. Then the question comes, how to proceed? What is the initial management? What are the basic investigations? Do we need to start any antibiotics and also any antiviral? Here, let's come see how do we proceed. The initial management, like any other child with respiratory distress, it's always supporting care. Because the child is sick, admit him and start oxygen in a convenient method for that particular age of the how the child tolerate, and give supporting care like in IV fluids, etc. And improve the nutrition. So what investigations are required? Like basic investigation for any ICU child, it's a CBP, along with, because the child is having a cough, cold history and respiratory distress, chest X-ray. These two are basic tests for this. So we have done these two tests for this particular patient. Then the word about the antibiotic. Usually, there is a tendency for all of us that whenever a cough, cold, fever case admitted in ICU, definitely we start the antibiotics. But in view of that, 70% of pneumonias are caused by the virus and only 30%. And in that also the community acquired pneumonia, usually the simple and bacteria. So it is better to use IMNCA guidelines. So preferably amoxicillin. But if any particular other risk factor is there, we can directly go for higher antibiotics. Next. So the case continued. The CBP is normal and chest X-ray showing bilateral interstitial infiltrates. And you can see that little hyperinflation also. That means some air trapping is there. And this case, viral panel has been done, and which showed the positivity for H3N2 of influenza A. Next. So does the case require antiviral? Because the X-ray picture is showing the viral pneumonia. Does this require antiviral drugs? Is the first question. Second, if so, which is most likely? Here, what is the benefit of antiviral drugs? Because we are all seniors must have read more about antibiotics and bacterial infections, but less about the viral infections, and that too antiviral drugs. Here, there are many reports say that antiviral drugs can shorten the illness if started within 48 hours of symptoms. And they should be prescribed by the doctor, as antibiotics are not all that effective in viral infections. So here we have started Oseltamivir 3 mg per kg body weight per day in oral form as a twice a day dosage schedule, and we have given for 5 days, which is effective in this case, even though the viral panel report came after 2 days, but because it is typical of viral infection and is a season for flu, influenza viral infections, so we have started Oseltamivir. Next. This child has improved here certain things. On what basis we thought of flu sickness? Because when we say that it is a viral infections, looking like viral infections, so we have to look for certain other criteria. In bacterial infection, usually one particular person in the family is affected, whereas in a viral infection, 3-4 members in the family are affected in a short span of 1 week to 10 days. That itself is a big clue for the viral infection. Second, in the case of respiratory illnesses, apart from upper respiratory infection illness, that is rhinorrhea, and even the lower respiratory illness, that is a cough and breathlessness. If they start both almost at a time, with a span of 1 day or like that, then the most likely it is viral infection than the bacterial infection. Even so, most probably we thought that clinically looking like viral infection. Then which virus? Because you can confirm only by viral panel, but we have straight away started Oseltamivir. So what are the emerging warning signs of flu sickness? How to detect that this particular infection is belong to the influenza? So usually children with those who are having a fast breathing or trouble breathing, bluish skin discoloration, and not drinking any water, and not waking up or not interacting, or being so irritable that the child doesn't want to be held. And these are all some of the flu signs along with severe respiratory distress. Flu-like symptoms improve, but then they return with the fever and worsen cough because of the secondary bacterial infections. Sometimes they may present with rash also. Here, there are in a small child, less than 1 year child, there is a poor feeding, there's a trouble breathing, and no tears while crying, and significantly few wet diapers than normal. That means the signs of dehydration. When these signs are there, along with difficulty in breathing, think about viral pneumonia. Next. So we have to think why to treat flu, because already the 5 days illness is over. And there are reports saying that first 48 hours, if you start antiviral drug, effect will be more. But still, even better late than never. Because even if you start later, it can prevent complications of flu like pneumonia, that is secondary bacterial pneumonia, bronchitis, ear infection, worsening of the existing disease like asthma, COPD, or ARDS, or death. So don't think that it's already late. It should be given on the first 2 days. You can start away. We have started this case and which showed the good result. So as such, the treatment of influenza is mainly supportive, like a bed rest, increased fluid consumption, and cough suppressants has almost no role, especially dextromethorphan like containing or antihistamines should not be given for all cases of lower respiratory infections. Next, antibiotic can be given as a paracetamol, and that is most preferred one. So usually it is there are the rates are there, like OP therapy. Most of the patient will recover in 3 to 5 days. Even IEP patients may go into respiratory distress and oxygen requirement. But again, if you diagnose and start antiviral drug, they'll also recover in 3 to 5 days. Next. Here, some knowledge about the antiviral drugs. The influenza virus has two components. One is a neuroaminidase that's an enzyme in the cell wall, and second is adamantinase. So these two enzymes are very important in the influenza virus, and this particular drug like Oseltamivir or Zanamivir, they block viral neuraminidase enzyme, which is very, very critical in releasing virions from the infected host cell. And what is interesting is both this Oseltamivir is effective against both strains like A and B of influenza. Whereas adamantinase, here we used to read also that was one of the first antiviral drug, that is amantadine, but now it is no longer used. Their mechanism is to interfere with hydrogen ion channel activity of the influenza that blocks the entry of the into the cell. Here, this picture shows the how the oseltamivir activity is there. This neuroaminidase is the enzyme which is blocked. Because of the neuroaminidase, there are more virions occur, and release of these new virions cause continued viral replication. That's how the virus replication and multiplication occur in the infected patient, and that will spread out. So here, because this oseltamivir is known to inhibit neuraminidase, the release of new virions, so multiplication of the replication of the virus and release of new virions is halted. So this is very, very effective drug by acting over the neuroaminidase. So on the whole, oseltamivir is a potent and selective inhibitor of neuroaminidase enzyme for both influenza virus A and B. As such, the pharmacokinetics, if you take, oseltamivir is a prodrug which is converted to its active form as oseltamivir carboxylate in the liver. So it basically mechanism of action is inhibition of the viral replication, and it also prevent further infection. And efficacy wise, it is effective against both strains of A and B influenza. So oseltamivir is the first new oral neuroaminidase inhibitor. This is one benefit, because most of the viral antiviral drugs are to be given either the injectable forms, either IV or IM, but this particularly it is available as oral drug also, and it is approved in more than 100 countries, including USA and UK. Next.
Yes, sir. Thank you, sir. So the first case is a straightforward case. Child is having toxic look with respiratory stress, and panel has shown H3N2. So we started with oseltamivir. Child improved and got discharged. So oseltamivir is a beautiful drug and the first oral neuraminidase inhibitor, and it's got approved in more than 100 countries. So better to give the oseltamivir so that the child will be improved and hospitalization is not necessary for most of the cases. If hospitalization also, if the panel comes positive H3N2 influenza A, definitely we have to give the oseltamivir. So the next case, Sungoj Bhaskar sir, please.
Thank you, Dr. Sridhar. And, good afternoon to our panelist, Dr. Sri Krishna, and moderator, Dr. N.L. Sridhar, and to the hetero family, my special appreciations for the hetero family, because this is a very useful panel discussion, which is relevant to the present scenario, at least in Telangana. So we have the second interesting case. It's a 6-year-old girl presented with fever and rhinorrhea since last 6 days and cough since last 3 days. So these type of cases we are seeing in and out every day since last 3 months, ever since this monsoon had begun. So when we took the history, this child is a known case of bronchial asthma on irregular treatment. So the reason for choosing this case to present here is a child developing this seasonal viral fever, having a coexisting disorder, that is asthma. So we became little alert and we examined the child. The severe bouts of cough with less fever when they came to us. And when we auscultated, there were bilateral crepitations with mild wheeze. It tells us that there are lung airway secretions are there, which are being heard as crepitations. and wheeze is due to the bronchospasm because this girl is a non-asthmatic. So should we suspect flu infection in this child? Our questions were, should we suspect flu infection in this child? And if so, what is the criteria? And since there is a past history, is it a simple post-viral asthma, which may require only bronchodilators, but not antivirals? Naturally, we need to consider this case as a respiratory viral infection, most likely influenza virus respiratory infection. So the criteria is abrupt onset, severe presentation, headache, body pains, throat discomfort, malaise. So just for our information, when we suspected a flu infection in this child with a coexisting disorder of asthma, so our thoughts are, so any virus can trigger asthma. More so is true with the influenza virus. We all know asthma is an inflammatory airway disorder, and as well we know the viruses which infect the lung, it causes inflammation in the airways. So these two factors will worsen the clinical presentation in a child having asthma. This flu infection, as we told you, it can cause potentially prolonged illness with persistent severe cough, requires prolonged hospital stay, and sometimes even very poor outcomes. However, all asthmatics, they advise the idea of presenting this case is a child having asthma, that is a coexisting disorder, should have annual flu vaccine along with the other preventive measures to prevent complications associated with the flu infection. So similarly, we had seen a case 8 weeks ago. A 12 years old boy presented with fever, cold, cough on day 3. So when he came here, he was looking sick. The tachypnea was there, irritable and restless. When we took the history, he's a known asthmatic, again on irregular treatment. So we had admitted him, we had treated him on day 3 of admission, fever had subsided, but breathlessness has started increasing. And we were unable to manage with simple oxygen. Then we switched that boy to HFNC. And it took for us 4 to 5 days of pediatric intensive care unit level 3 to stabilize that child. Even then, the cough was not completely eradicated. So we had to do bronchoscopy. We sent the lung secretions, and the report came out to be bronchopulmonary aspergillosis. Then, after starting antifungal, child became absolutely all right, and we discharged him. So what I'm trying to say is, it may be a simple influenza virus, but it can cause these uh, these what you call fatal, sometimes fatal complications associated with this simple virus. So, what are the guidelines? What are the recommendations for this viral respiratory infections? So, World Health Organization recommends empiric treatment in respiratory viral infections in at least high-risk group patients and as well in patients. And the empirical treatment should be started as soon as possible because just now we heard one of our co-panelists, Dr. Sri Krishna, has clearly mentioned that the treatment has to be started early to prevent the complications, to decrease the hospital stay, and probably to decrease the mortality associated with this virus infection. So do not wait until you get the RT-PCR reports to confirm the diagnosis. Secondly, it has its own pitfalls. This viral panel reports, they are not, the sensitivity and specificity is not very high. You can have false negative, sometimes false positive as well. So whenever you are exposed to a high risk individual, just now I had mentioned you in our presented case, the child was a high risk group because child was an asthmatic. So when they are exposed to a patient uh, to this infection, we need to start this Oseltamivir empirically. And these high-risk individuals who are not infected but exposed to a patient with influenza, better to start prophylactic treatment with oseltamivir to prevent the infection, or even if they are infected, the complications will be less. So early empiric supportive therapy and monitoring, uh, like in severe acute respiratory illness, we should think of giving empiric antimicrobials to all likely pathogenic viruses, and and depending upon your hospital antibiotic stewardship program, if required, you can start. If you strongly suspect there is a super infection, a secondary infection, or if you think it's a bacterial, you start the antibiotic of your choice. And particularly, we should be very careful about the nosocomial infections, wherein we need to start an antibiotic until proved otherwise. So, what is the empirical therapy? It includes, or it's mainly neuraminidase inhibitor, that is oseltamivir, for the treatment of influenza virus infection when there is a season going on or any other risk factors are associated, like travel history or exposure to the animal influenza viruses, which are mainly influenza A viruses. So in adults with community acquired pneumonia who test positive for influenza, should the treatment regimen include antiviral therapy? This we had already discussed. We strongly recommend anti-influenza treatment with oseltamivir to be prescribed for adults with community-acquired pneumonia, particularly those who test positive for influenza. You need to start empirically, even otherwise, without waiting. To prove our observations, several studies suggest that treatment with oseltamivir is associated with the reduced risk of death in patients, and as well the decreases the duration of stay, and as well it decreases the complications. Ideally, if we can, we should treat the patient within 2 days of the symptom onset to have a better outcome. But if we miss it, doesn't matter. Do not delay it further and start immediately, because it has some benefit in decreasing the complications and as well the duration of the stay. So we'll go back to the same case. We did CBP, which was normal. We did chest X-ray. It was showing hyperinflation. Again, because of this child is having an obstructive airway disorder, asthma, and we could see some interstitial infiltrates. And the virus panel report has come to be H3N2 of influenza A. So it's a confirmed case of influenza A, and uh, uh, thankful to our presumptive diagnosis, and thanks for starting oseltamivir empirically without waiting until we get the reports. So the child was given oseltamivir along with asthma management and supportive therapy. And once fever controlled, once the child became all right with no difficulty in breathing, we discharged her, advising the asthma therapy, that is mainly about the metered dose inhalation therapy. And child
Yes.
was discharged.
Thank you, sir. Here, the important why this case was taken. The child is already, the past history is there. The child is asthmatic. So, child, when the symptoms are seen, we can, with that practicing doctor, can get confusion about the child. We have to give importance for the asthma or the present scenario of because of this monsoon and influenza illness. We have to. So, this is that's why you have to keep in mind whenever the asthma exacerbation is there, the influenza per se can cause exacerbation of the asthma. So viral infections will aggravate the infections what child is having already. So we have to keep in mind, we have to treat the balancedly both the asthma and this influenza illness. So oseltamivir started, panel was sent, positive is there. Oseltamivir started, child improved. When the discharge was advised, we have to give the supportive treatment and also asthma treatment. The most important is we have to discharge and prolonged asthma treatment. So thank you, sir. This is a beautiful case, sir. And next case, Sorumpur Sri Krishna garu. Please, sir. Third case.
Thank you, Sridhar. Here we have a 2-year-old boy admitted with high-grade fever for 2 days. along with cough and cold for 2 days and breathlessness. The child on examination is restless with a respiratory rate of 60 per minute. That means it's very high. And the fever of 103 Fahrenheit is noticed. How do we manage this case? What is the initial management? Here already we discussed before about the antiviral drugs can be started before we get the report of viral panel. So this particular case, is it right choice for antiviral therapy? So let us see. Here the initial management, like any child with respiratory distress, should be supporting care, like giving oxygen and IV fluid support. If needed, the distress is severe, we may go for ventilatory support also. And what is the role of presumptive antibiotics? As already we discussed, that it is as per the guidelines of IMNCA and also the local hospital policy, you can start the antibiotics. Do you want to start presumptive anti-flu therapy with oseltamivir? If so, what is the criteria? Here, because previous days we used to start antibiotic routinely. Now, this particular nowadays they are prescribing antiviral routinely in the beginning, but there is a criteria here. This particular, what is the criteria to choose whether to give antiviral drug or not, especially for influenza, is whenever you suspect that this particular case is a suspected case of influenza, that is a fever with a severe cough and sore throat, or already confirmed case with a viral panel. So definitely they need oseltamivir, and having underlying conditions that increase the risk of complications of influenza. We know that the patients with a chronic heart disease, chronic lung disease, or a malnutrition, or the patient on any immunosuppression, they are at high risk of getting complications of influenza, which I told in the beginning itself. There are multiple complications with influenza. So they can be started straight away with antiviral drug. So antiviral treatment should be initiated as early as possible. Remember, if we start in first 48 hours of infection or illness, then the chance of recovery is very high. So even late, if you start also, better late than never. So this particular child having CBP picture of lymphocytosis and neutropenia, which is again a typical of viral infection. Chest X-ray shows bilateral interstitial infiltrates. The viral panel H3N2 for influenza A is detected, and we need to start the oseltamivir. Yes, what are the dosages? Here, see this particular chart has given very clearly what is the dosages. As such, it is a 3 mg per kg is the dose recommended of oseltamivir. In this, if you take in that sense, for adults, it is 75 mg capsules are available, which should be given twice daily. Whereas for children, it is a 60, less than 15 kgs, it is 60 mg per day, divided in twice daily doses. And later in the 15 to 23 kgs, it is a 90 mg per kg per day. And 23 to 40 kgs is 120 mg per day, divided into twice daily doses. And more than 40 kgs, 150 mg per day, divided twice daily doses. That means above 40 years, it is like an adult dose. Okay, so it is divided into twice daily dose as a therapeutic drug. The same thing available as a oral suspension also, which is available as a 1 ml contains 12 mg of oral oseltamivir suspension. So because as per the 3 mg per kg body weight, we can go for less than 15 kgs child, it is a 2.5 ml per dose twice daily. And like this, 40 kgs, 23 to 40 kgs, it is a 5 ml twice daily. So what is the oseltamivir chemoprophylaxis? Because sometimes we need to give even one person in the family is having flu influenza and one particular patient is immunocompromised. Here it is given, the center table has given clearly what is the chemoprophylaxis of the oseltamivir. The dose remains same, 3 mg per kg, but it is given for 10 days. Whereas in therapeutically, we give twice daily, whereas here it is once a day. So these are difference. Next. So the same child is having 5-year-old sibling with nephrotic syndrome on steroid therapy. This is what interesting in this particular child. So what is the risk for, because of the child sibling is having nephrotic syndrome on steroids? So what is the risk for him? So do we recommend preventive therapy? As we know, steroids are immunosuppressant drugs. There is a high risk of getting that particular child also getting the influenza. So what do we do? Do we start preventive therapy? And sometimes we do get. Will he improve with vaccine? Sometimes our patients also do come. We asked for whether vaccine is been given or not, like measles and other thing. Then already when established measles, then at that time they want to take vaccine. Yes, sir, we are ready. This is similarly even for flu also. When we ask them about the symptom, they tell that yes, sir, we are ready to take now. But of course, there is no role of vaccine when the child is already on steroids, and he should receive only prophylactic antiviral drug, that is Oseltamivir. So is it the same dose? I already repeated that it is a 3 mg per kg per day, but it's a OD dose, and it should be given for 10 days. This particular preventive aspect. Yes, next. So for symptomatic children in the OP setting, because this is an OP setting, the sibling is has not been affected, not been admitted, but is asymptomatic also now. But do we need? Yes, because of the immunosuppressant therapy, he needed. Then what is the guidelines says that in OP setting, for all symptomatic patients who are not at high risk of influenza complications, you should go for antiviral therapy, and better use initiate the therapy within 48 hours. Second is, it also may be considered for children with suspected or confirmed influenza disease whose siblings or households contacts are there, and all if there is anybody in the family is less than 6 months and their elder brother or sister got admitted with influenza, yes, this particular child with say less than 6 months is at high risk, so he should be started with the antiviral drug. So these are the main antiviral high risk condition which predispose to the complications of influenza. So this is about the preventive therapy. Basically, as we know, the prevention is two type. The one is vaccination is the best method of prevention for influenza, but it should be given at least 4 weeks before the disease, onset of the disease. Then only it is going to be useful. Next.
Thank you, sir. So few important points are, one is child is having, the sibling is having nephrotic syndrome on steroids. So message is, on treatment with on steroids, you shouldn't give vaccine. And child sibling is having, other sibling is having infected influenza. So better to give the as a prophylaxis for 10 days. So first point. Second important point is, best is before 2 weeks you shouldn't give the Oseltamivir. After 2 weeks you can give the Oseltamivir till adult. Adult dosage is 75 grams, 75 mg BD for 5 days. And coming to the children, you remember 0.25 ml per kg per dose. It should be given for 2 times a day for 5 days. You remember 0.25 ml, it will be easy for you. And 5 ml will be containing Fluvir containing 60 mg. So Oseltamivir will be there for 60 mg in 5 ml. If you 10 kg weight means 10 into 0.25 ml, 2.5 ml BD. Remember this, only 0.25 ml per kg twice a day. That will be sufficient to calculate the dose. So now I request us, Sungoj Bhaskar sir to say about this case 4, sir. Please. Sachin. Okay, great. Okay. Thank you, sir. Webinar log. Sir, Sungoj Bhaskar sir, please.
Yeah, thank you, Dr. Sridhar. And again, we are presenting one more complicated case. So here, 12 years old girl was admitted with fever and joint pains since last 4 days, along with mild cough since last 2 days. So gender-wise, she's a girl, age-wise 12 years, admitted with the joint pains and fever. Immediately, one entity which comes into our mind is, are we dealing with any autoimmune disorder of new onset or of a pre-existing one developed the relapse? When we took the history, she is not a known case of chronic lung disease. That is another form of autoimmune disorder, or you can also call a connective tissue disorder. And then when we examined, the child was restless with cough and low-grade fever. Arthritis, mild form of arthritis was present. And when we auscultated, there were bilateral crepitations. So here we were a little puzzled how to move forward. Should we suspect flu, that is influenza viral infection, along with autoimmune disorder? If autoimmune disorder is there, on top of it, if this girl had infected with the influenza A virus, so how is it going to alter the disease course? So we know the viral infections can exacerbate or exaggerate these autoimmune issues like interstitial pneumonia. It can worsen in those individuals who are predisposed to that or who have already this interstitial lung disease. So we took CVP, no specific information, it was normal. And when we took the chest X-ray, it was showing bilateral interstitial infiltrates, otherwise nothing significant. And we did anti-nuclear antibodies to rule out autoimmune disorders to some extent, and it was normal. So then we thought the child is not a case of autoimmune disorder. Then we did viral profile, and which had clearly shown that this nasopharyngeal swab of this child is having influenza type B. So our diagnosis was confirmed in this girl that it's a case of influenza A virus infection of the lungs, and we could rule out autoimmune disorder. But the idea of presenting this case with that age, the presentation, we should always remember the viral infections can aggravate these connective tissue disorders in a in a child who is prone to develop these diseases. It can worsen ILD in people with underlying connective tissue disorder. And also, the frequent repeated viral infections might play a role in the development and progression of connective tissue disorder, particularly interstitial lung disease, if the child is prone to develop the disease. If child is not prone to that, he or she will not get interstitial lung disease. So the message here is all patients with autoimmune disorders or connective tissue disorders, again, they should receive every year vaccination against influenza without fail. And whenever there is a viral lung infection, we should start Oseltamivir empirically in routine doses at the earliest. So that was the idea of presenting that earlier case, just to throw some light on the role of influenza A virus infection in children who have connective tissue disorders. Now we'll move on to theoretical discussion. Any change of clinical picture, medical medications, management between influenza type A and type B. Essentially speaking, there are no much differences. Influenza A is severe in children and as well in adults. Influenza B is severe in children and may not be that severe in adults. That's the only minor difference. The constitutional symptoms are severe in both A and B. They are sudden in onset and they are severe. And the commonest constitutional symptoms we should remember: fever, throat discomfort, body pains, malaise, then cold and cough, sometimes vomitings and diarrhea. Complications like pneumonia is the same in both influenza A and B. The only interesting factor is mutations are more common with influenza A viruses, whereas mutations are very uncommon in influenza B. We all know the influenza A virus can alter its this genetic structure, particularly it can change the cell wall proteins to become a different structure, or it can have this antigenic shift, which is very dangerous. If a child is infected with two different viruses, and there can be a genetic reassortment leading to a new serotype, new strain that can cause havoc, that can cause pandemics. That is the only problem with the influenza A. Whereas influenza B can have this antigenic drift, which can present seasonal forms, seasonal epidemics. And influenza A, unlike B, it can infect even other animal species. So the chance of spread is more, chance of having zoonotic disorders are more common with influenza A. Next, please. Next, please. So, as already
Yes, sir.
discussed by our moderator and our co-panelist, Dr. Sri Krishna, the preventive measures are mainly two. One is non-pharmacological, another is pharmacological and vaccinations. So we know, thanks to the pandemic 19, we know well about hand hygiene. We should wash our hands very frequently, particularly healthcare professionals. We should wash our hands as frequently as possible before touching another patient in ICUs. If that is not possible, at least you can use alcohol-based hand rubs before touching a new patient. And another thing is we should wear masks in ICUs. And when you're moving out, when you get cough or sneeze, better cover your mouth with handkerchief or tissue, so that, and it should be thrown away cautiously. Or at least if you don't have anything, you cough or sneeze into your elbow. That can decrease the spread by aerosols or these droplets. And we know the viral infections can spread through fomites. So you should always clean your tabletops, your mobile, your frequently used doorknobs like bathroom doors, bathroom taps, particularly when a family member is ill or when you're working in a hospital. So vaccination is the best preventive modality to prevent the infection with influenza virus A and B. And we should take it regularly every year from 6 months above to any age, as Dr. our moderator said, any age, it should be 70, 75, doesn't matter. And Oseltamivir is a boon to us, it's a boon to the physicians, boon to the patients who are suffering from influenza virus infections. We should not hesitate to use it prophylactically when there is a high-risk child or person is there, when he might get exposed to already an infected person. So these are the some of the preventive measures we should adapt.
Yes. Uh, this is a beautiful case, sir. Why important means child is 12 years and having a joint pain. So we in H1N1 commonly we don't see the joint pains and the age. So thought of connective tissue disorder, it may aggravate because all the influenza, as earlier said, influenza virus can aggravate all the existing diseases also. So that's the reason why we have to keep in mind. But ANA profile is negative, and in this case, oseltamivir started. And important thing in this case is till three cases we have seen influenza A was registered. This case, influenza B was diagnosed. That's the important. That's why 60 to 70% cases are influenza A. Only 20 to 30% cases will be influenza B. That's why we made it easy to remember the differential diagnosis. What is influenza A or B? Any treatment modality will be. There is no treatment modality will not be changed, and we have to give the oseltamivir, but for both the A and B, and child will be improved. So thank you for this, sir. And a proper diagnosis can and early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory tract complications and hospitalizations and antibiotic use. And WHO and American Thoracic Society, and the Ministry of Health and Family Welfare recommends empiric use of Oseltamivir. So I thank my panelists, both the Dr. Sunkoj Bhaskar sir and Surampudi Srikrishna garu, for enlightening with beautiful cases. Thank you. Special thanks to
Thank you very
Srikrishna garu,
much.
sir. Thank you, sir. Thank you, Prashant.
Thank
you,
you.
Prashant.
Thank you so much.
Thank
Thanks,
you.
Dr. Sridhar. Thanks, Dr. Sankos. Thanks, Dr. Sri Krishna. It
Thank
was
you.
lovely, insights into the happenings and influenza is really great. I'm sure the audience benefits out of these interactions. Certainly. Thanks once again. Wish you a very pleasant evening. We can sign off, sir.
Thank you,
Thanks for
Hetero.
the
Thank
debate.
you.
Thank you.
Thank you.
Thank you,
very
Dr.
much.
Prashant. Thank you all.
నేను మామూలుగా అన్నా